This is Lindsay Luther, and I'm going to be giving a presentation on primary care for the breastfeeding dyad. I am a family nurse practitioner by certification and by practice. I am not a licensed or certified lactation consultant. This presentation is meant to give you enough background information so that you can adequately provide primary care to mother and child who have a breastfeeding relationship. This presentation will not teach you everything that you need to know regarding breastfeeding, and it certainly is not enough to help you get certified as a lactation consultant, but it is a good start for the person who may not have a lot of experience with this clinically, or who may only have personal experience with this. I will say a couple of warnings. First, this presentation does have some images of both normal and abnormal female breasts, and so it may not be suitable for all viewing environments. You may want to take a second to look around, make sure that if anyone can see your screen, that you are comfortable with them seeing your screen. I will also just say that this is a topic that comes up a lot in just day-to-day life as far as social media, and there have been a lot of public awareness campaigns regarding breast is best, and so I think most people have some feelings on this subject, and I would ask that you just sort of explore what those feelings are and try to set them aside during this presentation so that you can learn a little bit more about why we make the recommendations that we make as far as primary care. Okay. We know there has been a significant amount of research on breastfeeding, and we know from this research that there is a good benefit to both the mother and the child of breastfeeding. Benefits to the mother include reduced risk of certain conditions, including ovarian and breast cancer, cardiovascular disease, diabetes, hypertension, and postpartum depression. The primary benefits, however, are for the infant. So breast milk is magical in that throughout a breastfeeding baby's time of breastfeeding, the volume of milk that the child intakes remains almost entirely consistent. So after those first few days when the infant's stomach is still expanding and they're learning how to eat, the infant will take approximately the same amount of milk between 2 weeks of age and 6 weeks of age when they start solid food, or 6 months of age when they start solid food, And what changes during that period is the composition of the breast milk. So as the child experiences certain needs as far as protein, calories, fat intake, etc., the milk will actually change in response to those needs. The milk will also change in terms of its immune modulating substances. So we know that breast milk has some anti-inflammatory components, some anti-infectious components, and it also aids in digestion. Probably because of these immune modulating properties, we see some reduced risk of certain conditions in childhood, and these include atopic dermatitis and gastroenteritis. The Promotion of Breastfeeding Intervention trial included more than 17,000 breastfeeding mothers and children and found that breastfed infants had lower rates of gastroenteritis and atopic dermatitis, as well as nearly 6-point higher overall IQ later in life than infants who were not breastfed. Now, the IQ difference is interesting in that it was statistically significant, but take that with a little grain of salt because this may or may not be clinically significant. So does 6 points of a higher IQ actually matter in terms of what you're able to accomplish or process or whatever? Maybe, but maybe not. The potential benefits have been noted in observational cohort studies as well. So for example, we've seen the benefits of GI health related to breastfeeding from studies that were performed in countries that have an increased risk of water and foodborne illnesses. And then there have also been some studies that show that that breast milk may reduce the risk of childhood leukemia, hypertension, necrotizing enterocolitis, obesity, otitis media, chronic respiratory illness, SIDS, and diabetes. So keep in mind that cohort studies are a little bit lower on the evidence ranking as far as the strength of the evidence, and so these are not, meta-analyses of random controlled trials, and so some of these findings have yet to be fully validated by those higher level evidences. So this brings up our next question, which is breast best? So you've probably heard of the Breast is Best campaign, which was the public health campaign that's been going on for many years to encourage women to breastfeed. So from the perspective of public health, the answer is that absolutely breastfeeding is best. There are a number of reasons why. First of all, breast milk is the nutritional gold standard for infants. As I explained before, breast milk changes in response to the needs of the individual infant, whereas formula is a human milk substitute that relies on other animals or plants for its protein content. So unlike breast milk, the composition of the formula cannot change based upon the needs of the infant and the environment. We also know that breast milk quality of nutrition is not compromised by the water supply. So even if the mother drinks unclean water, most of the time the breast milk will still maintain its high quality in terms of nutrition. And it doesn't get diluted in the way that formula can be diluted by the amount of water that's put into the formula. And also there are no manufacturing processes involved. And that not only limits the potential of substances to make their way into the food product, but also reduces the environmental impact of feeding babies. So less packaging, less waste, less industrial processes that produce pollution. People like to say that breastfeeding is free, and that's not true in that there are a number of supplies involved, and also there is a significant time investment from the mother. And if you think about the mother's time in terms of productivity and time lost, certainly the time spent breastfeeding could be considered quite expensive. However, straight out-of-pocket costs, formula feeding tends to be more expensive. As we mentioned before, there are health benefits for both the mother and the infant related to breastfeeding. And then one of the most important public health benefits is that access to breast milk is preserved in times of emergency and natural disaster. So in areas where there are endemic health challenges or where there are frequent natural disasters or emergencies, having a sustainable and reliable food source for infants that is not dependent on the water supply or on external substances is a real bonus. Now, all of that said, from each individual mother's perspective, breastfeeding might be best or it might not be best. So there is a significant physical, financial, social, and psychological investment from the mother, from the family, and then there's also a relationship between the mother and the family, or between the mother and the infant, that affects the success of breastfeeding. Breastfeeding can be extremely time-consuming. So a mother that breastfeeds for a year may spend anywhere between 800 and 1,500 hours producing breast milk, feeding the infant, and pumping breast milk to send the infant to wherever the infant is going for the day. So it depends on the mother whether or not breastfeeding will actually be best for that particular family. And that's something that you're going to want to keep in mind as we move forward. Okay, so all major health organizations recommend that infants should breastfeed exclusively for the first 6 months of the infant's life. So that means that there should be nothing entering the baby's mouth besides breast milk for the first 6 months of the baby's life. At 6 months, the weaning process begins. So weaning starts as soon as the infant starts to ingest solid foods. So at 6 months, solid foods and small bits of water can be introduced, but breastfeeding should actually continue throughout this process until at least 12 months. The expression that we like to use is food before one is just for fun. So the idea is that you're not giving the infant food for them to eat as a way to supplement their nutrition, but rather you're giving them food so that they can learn how to eat, so that by the time that they're one, they can take in enough nutrition from solids that they don't require breast milk anymore. There have been some studies that suggest that a longer duration of breastfeeding does benefit the infant. It In other places around the world outside of the United States, it is common for children to continue breastfeeding through toddlerhood and into early childhood. So age 2, 3, 4, 5 is not unheard of. The United States actually has one of the very shortest breastfeeding rates and durations in the modern world. So you can see here on the left that about almost 58% of infants are breastfed at least to some degree through 6 months, but a very small proportion, less than a quarter of infants, are exclusively breastfed through that first 6 months. So that upper statistic includes infants who receive some formula in addition to, or solid foods in addition to breast milk. There are a number of reasons why moms discontinue breastfeeding. We know in the United States, over 80% of mothers who are able or who anticipate being able to breastfeed will start breastfeeding, but only about 52% of those, between 52 and 58, depending on where you look, I know you saw that last slide, will continue for about 6 months, and somewhere between 25 and 31% continue for a full year. So we do know that a longer duration of breastfeeding is correlated to maternal education, support for moms, paid maternity leave, health insurance, and many other factors. Some of the main reasons why moms discontinue breastfeeding is that they have either a real lack of milk supply or they have a perceived lack of milk supply, and we'll get into that in a minute. The rest of the other reasons are pretty much infant related. So a poor latch will result in nipple pain that can make breastfeeding intolerable for the mother. There are other causes of nipple pain besides poor latching, and we'll go through those as well. So just very quickly, if you look over here on the right side, you can see that there are a lot of supplies that are marketed to breastfeeding moms. Not every mother is going to need all of these things, and depending on whether the mom is only breastfeeding the infant or whether they're also pumping or expressing milk for the infant will make a difference as far as what supplies they need. Most mothers will need some form of breast pump. It's helpful for all breastfeeding moms to have a breast pump so that they can express milk away from the child. It is possible to express breast milk entirely by hand without the use of a pump, whether manual or electric. There's a technique that can be used to do this, and it can be very effective if this is what moms choose to do. And some moms do choose to do that, but it does take a lot of practice to learn. So most moms, especially those who are going to go back to work, will get a double electric breast pump. That's the recommended pump for anybody who's going to be producing milk in significant proportions, as far as going to be away from home for extended periods of time. A manual pump can work really well for a mom who just misses occasional feeding. So for example, if a mom is staying at home with the child but every now and then likes to go out for a few hours here or there or works as a casual employee, a manual pump may be more than enough. It's basically the handheld version of a pump. Anybody who's pumping breast milk is going to need a way to store that breast milk, and so they're going to need storage bags and bottles. You also need backup supplies for the pump, including flanges and membranes. Those need to be changed out every once in a while, usually about once a month. And a pumping bra can be really helpful for a pumping mom. Basically, it allows for hands-free setup so that you don't have to hold the cups in place and you can do other things with your hands. Especially in the beginning, nipple cream can be helpful, at least in terms of comfort for the mother. Lanolin is the most commonly recommended nipple cream. However, there are a lot of other creams that can be used, and you can even use food-safe oils. These can be used to lubricate the pump as well, but the mom will need to check her individual pump manufacturer's instructions to make sure that she's using an oil that's compatible with the plastic that's involved with the pump. Coconut oil and vegetable oil, olive oil, all work well. There are also a lot of commercial creams available. Other items that might be helpful include nursing attire, so bras, tanks, and a cover to keep herself covered, as you see in that bottom right-hand picture. Nursing pillows and nursing pads, so they make both disposable and washable pads to catch breast milk that may leak out during the day. Women may need sterilizing supplies, so there are microwave sterilizing supplies, but you can also boil most pump parts. And then finally, women need to drink lots and lots of water, basically at least an ounce per kilogram of body weight per day. But ideally, they should also replace all of the water or all of the liquid that they're pumping out. So if they're producing 13 to 18 ounces of breast milk per day, they may need to also pump 13 to 18 ounces of breast milk per day. Actually, I'm sorry, they need to drink that much water per day. All of this to say, if you haven't gotten this message yet, that breastfeeding is not free. So all of these things can be expensive. Fortunately, breast pumps have started to become covered by health insurance, which wasn't true even 10 years ago before the ACA went into effect. So that has been helpful for many women. So before we get into problems that can occur in the breastfeeding mother, I want to take a moment and step back and look at the anatomy and physiology related to breastfeeding. So the breasts will develop minimally through childhood, and they pretty much remain stagnant until puberty, when they develop into adult breasts. After puberty, they will again enter a stage of stagnancy until pregnancy begins. During pregnancy, the stage 2 of mammogenesis begins, and this is stimulated by an increase in the amount of progesterone that's circulating through the body. This leads to the development of secretory tissue in the breast, and the size of the breast will then increase. This is what causes breasts to grow quite significantly in early pregnancy. The next stage of this is called ductal sprouting, which occurs in the first trimester, and that's when the ducts begin to further develop. And this happens secondary to chorionic gonadotropin production. And this will lead to a vast production of newly formed lobules that surround each duct. Once the second trimester begins, the secretory tissue will continue branching and colostrum starts to accumulate in the breast. Some women will start noticing as early as the second trimester and in the third trimester that there are small amounts of colostrum leaking from the breast. However, if this does not happen, that is not an issue. Most women are able, if they try, to manually express a small amount of colostrum during this phase in the second and third trimester. Just before and during labor, the glandular tissue of the breast will start to grow and differentiate, and this is associated with milk secretion. Lactogenesis, or the ability of the breast to secrete milk, comes in 2 phases. Stage 1 occurs during the second half of pregnancy, but the high levels of progesterone secreted by the placenta will prevent stage 2 from starting. So during that time, again, women are able to express a small amount of colostrum. Secretory activation, or phase 2 of lactogenesis, occurs after the placenta is delivered, and this results in a steep drop of progesterone and also an increase in the amount of prolactin, cortisol, and insulin. This allows a large amount of breast milk to be produced in the days following labor. This causes swelling of the breasts, usually about 2 to 3 days after childbirth, but it may take up to 7 days. This phase takes longer to begin in women who have not had children before, as well as in those who have had C-sections, or if they have any element of placental retention, diabetes, or a stressful vaginal delivery. However, eventually milk production should even out, and they should have the normal volume of milk production. If women don't have phase 2 lactogenesis, they should be suspected of having retained placental fragments, and so that's something that you need to be aware of. And then from this point forward, the breasts are ready and able to produce milk, and maintenance of milk production will then depend on removing milk from the breast and continually stimulating the nipple and the breast. So you can see here on the left that there is a feedback loop that exists between the HP axis and the breast. And the hormones involved are prolactin inhibiting hormone, prolactin, and oxytocin. And you can see here in this diagram how each one of those hormones is involved in breastfeeding and when they are released. Okay, so I mentioned that in order to maintain a milk supply, milk needs to be removed from the breast and the nipples need to be stimulated. When the nipples are stimulated, this triggers a release of prolactin and oxytocin from the pituitary gland. And in contrast, whenever the pressure inside the breast is high, so whenever the breast is full of milk, this results in a negative feedback, and lactation is inhibited, so milk supply will be reduced. This will trigger mammary involution. So the main takeaway that you need to understand with breastfeeding is that you will get as much milk as you take out. So if women don't pump enough or breastfeed enough, their milk supply will go down. Basically, it's entirely demand dependent. So it's helpful to understand the feeding patterns of newborns to understand exactly what it takes to maintain a milk supply. So a newborn is expected to nurse between 10 and 12 times per day, and each one of those nursing sessions will last between 20 and 40 minutes. So if you're really good at math, you've probably figured out that the newly postpartum mom is going to be breastfeeding for somewhere between 4 and 8 hours a day, and that is exhausting. So it's something that moms really have to have a lot of perseverance to get through those first few days, and that's why moms need a lot of support both in the hospital and in those first few days of release from the hospital. Brand new infant just born will only take in about 2 to 10 milliliters per feeding. But by day 5, the baby's taking in about the full amount of breast milk. Up to 2 weeks, really, it takes for that to be totally consistent of 2 to 4 ounces per feeding. So 2 to 4 ounces is the volume that will remain consistent pretty much throughout the duration of breastfeeding. The nutritional content of the milk will change to meet the needs of the infant, as we explained before. That is the magic of breast milk. The amount stays the same, but what's in the milk changes to meet the needs of the growing baby. And I want to point out that it's very unusual for a nursling infant to drink more than 5 or 6 ounces in one feeding. And usually if the baby is having more than 5 or 6 ounces in a feeding, it's because of the adult that's feeding the baby is overfeeding from the bottle rather than the infant actually wanting and needing that much milk. There may be another need that the infant has that's not being met. Okay, so there are a number of positions that can be used for breastfeeding, and these are things that you can recommend to your patients. I want to just point out on the right side here the sandwich technique. This is also called the flipple, which I think is a really cute like nipple and flip. So basically, you use the thumb and the second pointer finger to create a sandwich that sort of lines up with the baby's mouth, and then you sort of drag the underside of the nipple just into the baby's mouth. Basically, if you can tell right here, there's a much more of the baby's mouth on the underside of the breast once they're latched on than there is on the top of the breast. Most new moms will attempt to approach the infant's mouth head on, and really rather than that, we kind of want to drop the nipple into the baby's mouth. This will allow for the most comfort. And in any position that the mom is going to use for breastfeeding, the baby needs to come to the mom. If the mom is moving forward or sideways to get her breast into the baby's mouth, what's eventually going to happen is that the baby's going to have a poor latch, or the mom's going to end up with chronic back, wrist, and shoulder pain. So I just wanted to show you that there's a lot of options. I want to point out that there are a couple of sort of unusual positions on here. Most of the time when you hear about teaching new moms how to breastfeed, you see 3 positions. You see the cradle hold, the cross cradle hold, and the football hold. The cross cradle and the football hold work really well for brand new babies because the infant's head is very well supported and the infant's head is right in the mom's hand, so she can direct the baby straight to the breast. And that's why we tend to use these positions more in the hospital. The cradle hold is really helpful for heavier, older infants who know how to latch on by themselves. It's just a quick and easy position that the mom can get into, and also it's a position that works well with infant baby carriers. The other positions that you see here, I want to point out because these are really great for moms who have specific needs. So for example, if a mom has had a C-section, The inverted side lying position can be a really great position for her because it takes the weight of the infant's body off of her belly. Another good position after a C-section is the side lying cradle. For moms who are having a lot of trouble with getting a deep latch, back lying position can be really helpful because gravity helps the baby to open their mouth further and deepens the latch. The Australian hold is really great for infants who have reflux because they're sitting upright throughout the whole time that they're feeding, which helps to keep that lower esophageal sphincter a little bit more closed than when the baby's lying sideways. So that can be really great for a refluxy baby. And then the back lying and side lying and inverted side lying positions are all really good for a mom who is absolutely exhausted, because as long as there's someone else in the room and there's a safe setup where the baby cannot fall, these are really good positions for the baby to snooze, or for the mom to snooze in while the baby is feeding. Okay, so how do we monitor milk supply? So we monitor milk supply by looking at the baby, not by looking at the milk, not by looking at the mother. And this is tremendously important. As we said before, a lot of moms will discontinue breastfeeding because they think they're not getting enough milk. The best way to tell how much milk is being produced is by making sure that the baby is growing properly and the baby's body is functioning properly. So we can look at stool output, color, and consistency, number one. In the first few days, if the baby is urinating, then we know the baby is hydrated. So we want to make sure that the baby's having enough wet diapers a day. Breastfed babies will poop almost every time that they eat, especially in the beginning, because breast milk in the first few weeks is a laxative, and so every time that they eat, they poop. So keeping an eye on stool output can be very helpful. A weighed feeding is the best way for a healthcare provider to assess milk supply. So the baby is weighed with a clean diaper prior to initiating a feeding, and then the baby is weighed after the feeding with that same diaper on. So even if the baby goes to the bathroom, those ounces of milk are caught in the weighed feeding. 1 gram of weight change should equal 1 ml of milk intake. Similarly, 1 ounce of weight change should equal 1 ounce of milk intake. So you're looking to see, does the baby's weight with the diaper increase by somewhere between 2 and 4 ounces at the end of the feeding? And if the answer is yes, then they're getting an adequate amount of breast milk. If it's confirmed that the baby's not getting enough breast milk, then it's ideal to supplement with pumped breast milk. If you cannot supplement with pumped breast milk, then formula can be recommended. A lot of moms think that an infant's fussiness or the size or fullness of their breasts or the amount of breast milk that they can produce by pumping are good indicators of supply, and they are not. Pumping is 100% a head game, and if women are struggling with the breast pump, they may not get an adequate amount of breast milk, but if they are bringing the baby to the breast, they may get an absolutely fine amount of breast milk. When we talk about transferring, we're not just talking about the amount of milk that the mom is producing, but also how much milk the baby is able to take in. So it might be that the mom is making plenty of milk, so if she can pump 4 ounces, and the baby, though, is only able to take in 1 ounce, then the issue is probably with the baby's suck and their ability to take milk in. So we do have some signs of ineffective breastfeeding that we can monitor as healthcare providers. One is that the infant loses more than 7% of the body weight, or they continue to lose weight after day 3 after birth. When the baby is breastfeeding, if you can observe a breastfeeding session, you should be able to hear audible swallowing, and you should be able to see the baby's ears move when they're eating, because that indicates an actual swallow. If the baby's having less than 6 wet diapers per day or less than 3 stools after day 4, that's also a sign that there's not enough breast milk. And if the maternal breast has not had any changes whatsoever by day 5, that can indicate that there's some sort of delay, and that might be when you go looking for one of those complications we talked about earlier, such as a retained placenta. So any nipple pain that persists beyond 30 to 60 seconds after a feeding is started can indicate that there's something wrong with the breastfeeding process, whether that's an issue with the breast, an issue with the baby's latch, or something else, and we'll get to that in a minute too. So as I said a moment ago, the goal of a weighed feeding is to tell if a complaint that the mom has inadequate milk supply is actually true or if it's a perceived problem. So the ability to pump out breast milk can be affected by a lot of factors, including the equipment that the mom is using, the technique the mom is using, psychological factors, time, and then characteristics of the breast. A well-latched infant, as I said before, is much more capable of removing milk from the breast than a pump or even hand expression. So one of the most common complaints that you'll see is that moms feel like they don't have enough milk supply. So the question you need to ask is, if there truly is not enough milk supply, is it an issue with not enough milk being produced, or is it an issue with not enough milk being extracted by the infant? So inadequate milk production can be related to a breakdown of one of the processes of either lactogenesis or mammogenesis. So there's either an inadequate breast development, or there's a delay in the progression to lactogenesis stage 2. If a woman has had a breast reduction, she may or may not be able to breastfeed. It depends on how much of the glandular and ductal tissue was removed or severed during that process. Some women who have had a breast reduction can breastfeed, but others cannot. Most women who have had a breast augmentation or have had breast implants can breastfeed because they don't typically have to sever the glands or the ducts of the breast. There are also some medications that can reduce breast milk supply, and so you need to monitor mom to see if she's been using any of those medications. Problems related to inadequate milk extraction include not enough feedings or poor feeding routines. So the baby may be at the breast for 40 to 60 minutes instead of 20 to 40 because they're getting tired and they're not really pulling any milk out, or they're not doing a good job with sucking. It might be that the mom's not bringing the baby to breast often enough or not pumping enough when she's away from home, and so the breast's not getting emptied, and it's starting that negative feedback loop telling the breast to make less milk. The mom may just not respond well to the pump and may need a different type of pump, a different type of pump flange, or a different size flange. The flange is the round part that attaches to the nipple with the hole in the center, and I'll show you that in a minute. And then issues related to inadequate milk extraction are really diagnosed using history, weighed feedings, and by directly observing the infant at the breast. And also directly observing the mom using the breast pump. And this is something that a board-certified lactation consultant can absolutely help you with. So galactagogues are a type of medication that are used particularly in other countries to stimulate milk supply. There's very little evidence-based practice to support these agents, and there's also a risk related to these medications. None of them are approved for this in the United States, and so I would strongly caution you not to use them. However, many of your breastfeeding moms may have heard of these medications and may seek them out. So agents that you might hear about are domperidone and metclopramide. Okay, so another common problem that you'll see in the breastfeeding, early breastfeeding especially, is engorgement. So engorgement typically happens between day 2 and day 7 postpartum when the milk comes in for the first time. It is extremely painful, and you can see in this picture just how dilated the veins of this breast are. There's a technique, so first of all, the only treatment for this is to remove milk from the breast. However, you only want to remove as much milk from the breast as the breast is going to need for the baby. So when I say that, I want to caution you to advise mothers not to remove more milk than they need to remove for the baby, or it will tell the breast to keep producing that much milk. So moms should not pump if they can help it. They should try to avoid hand expressing a lot of milk. Instead, there's a technique called reverse pressure softening that it's basically a massage technique that allows for softening of the front part of the breast near the nipple, which can facilitate the baby to latch on better. Cold cabbage leaves, which have been kept in the refrigerator and broken, and then placed into the bra, can help with engorgement. The cabbage leaves release a product they release a chemical that's very similar to aspirin, and so it kind of serves as an anti-inflammatory, and then in addition to the cold, it can feel really good. Ice packs can be used to, in a limited fashion, to just calm the breast tissue down. And basically, the number one treatment is to make sure that the baby is latching on and removing an appropriate amount of breast milk from the breast. NSAIDs can help with pain. One of the complaints that tends to occur in relation to engorgement is if the engorgement lasts for an extended period of time, a woman can end up with a clogged duct and or mastitis. So a clogged duct is a tender and painful, palpable lump, the lump being the duct that is overfull, and it's due to a mammary gland obstruction. These are exquisitely painful and exquisitely tender. There is no question that something is wrong with the mom. She will present with an engorged breast, or at least a partially engorged breast. It may just be on one side, and there will be a hard, painful lump under the breast. If these ducts or these mammary glands get infected or inflamed, you will develop mastitis. So you can see in the picture here, the breast on the left is engorged, the breast on the right has mastitis, and you can see that the nipple is red and there's streaking that comes alongside the duct that is inflamed. If you were to touch here, it would be probably very hard. It would feel like almost like marbles under there. So this is also accompanied by fever, myalgia, breast pain, and redness of the breast. Mastitis basically feels like the flu in addition to a clogged duct. It's a very uncomfortable and awful feeling for a mom. The way that we treat just a simple clogged duct without mastitis is by massage, so kneading that painful lump. Vibration is actually very helpful, so using an electric toothbrush or even a vibrator against the skin can help to break up some of that clogged lump. And warm, moist heat can be very helpful. If you nurse the baby with the baby's nose pointed toward the clogged duct, that will help the baby to extract milk specifically from that duct, and that can facilitate emptying of the duct. It can take several feedings for this to happen, and it's not abnormal for mom to feel a sense of panic during that process because it is a very painful experience. For mastitis, we treat with either dicloxacillin or cephalexin. If the mom is penicillin allergic or cephalosporin allergic, you can use clindamycin. Keep in mind that whenever you're giving medication to a breastfeeding mother, and especially whenever you're giving an antibiotic to a breastfeeding mother, you need to make sure that the medication you're prescribing is not only safe for the mom, but is also safe if it does make its way into the breast milk for the baby, and that the medication will not reduce milk supply. Treatment of mastitis can involve NSAIDs or even stronger medications. I have actually seen patients receive opiate medications for mastitis. And first and foremost, the mom needs to keep emptying the breast regularly. Emptying the breast is the only way to get rid of clogged ducts. It is perfectly safe for the mom to nurse through the infection, even on the affected side. If there is blood in the breast milk, this will not hurt the infant. It will not irritate the infant's stomach. It is perfectly safe for the mom to feed the baby even if there's blood in the breast milk. Nipple problems are another common complaint, and so this is the differential diagnosis for nipple problems. Thrush is kind of thrush is a little bit controversial. Basically, thrush is a candidal infection of the breast, and it's kind of debatable amongst healthcare professionals whether or not this actually happens, and whether or not this is as big of an issue as it as we make it out to be. If you suspect a candidal infection of the breast, it's hard to confirm because it's normal for there to be some element of yeast on the skin, so a skin culture is not helpful. A breast milk culture can be performed in some cases, and that would be kind of the gold standard for diagnosis. However, there are not many places that will do a breast milk culture. And it's also very challenging to get a sterile breast milk sample. Treatment for this is topical antifungals for the mother and the baby. Now, if the baby has thrush in the mouth, you can pretty much guarantee that the mom will have some increased candida on the breast, on the nipple, and so both need to be treated at the same time regardless of whether the infection originates in the mom or originates in the baby. A nipple bleb is it's basically like a little bit of milk that's trapped underneath one of the pores at the tip of the breast. These can also be exquisitely tender, but they're just point tenderness right on top of that bleb. Treatment is by lancing that little bleb with a sterile needle. Inverted nipples are sometimes problematic for moms. Basically, the nipple is retracted inward instead of outward, and this can actually correct itself over time with breastfeeding. It can impair the way that the baby latches initially, however. So in order to fix this, the best thing to do is to start with the breast pump or with manual extraction, basically to get the nipple to engorge. And as the nipple itself starts to engorge, it typically will evert itself. And then if it does not, you can consider trying a nipple shield, which is a little piece of silicone that sits on top of the nipple and that basically holds a nipple shape and can allow the baby to transfer milk more effectively. Nipple injury can occur with or without infection, and it's usually secondary to a poor latch or suck. In older babies, it can be attributed to biting. It can also occur secondary to pump trauma, or if the infant has an issue that affects the way that they latch to the breast. So for example, if the infant has a stiff neck or a tongue tie. Nipple cream can be used for comfort, but there's not really a lot of evidence that it helps. We do know that exposure to air will help heal the nipples better, and then behavior modification. So if we fix the poor latch, if we fix the biting behavior, or if we were able to fix the physiologic issues such as the torticollis or the tongue tie, that can help as well. There is a substance called all-purpose nipple ointment that was developed by one of the breastfeeding gurus, whose name is Dr. Jack Newman, and this is a mix of an antifungal, a steroid, an antibiotic. Ooh, there's one more thing in it, and I can't remember what it is right at this moment. But basically, it's a combination nipple ointment that will treat almost anything. So if you suspect infection and you're not really sure if the infection is, if it's bacterial or if it's fungal, but there's obvious nipple injury, then using an AP&O can be helpful. And basically, these are written as a prescription that are sent to a compounding pharmacy, and the compounding pharmacy will then put these medications together. These can actually also be mixed at home using over-the-counter treatments. So I believe they use They use miconazole, bacitracin, hydrocortisone, and there's one other medication that's in the cream. But there are recipes online that you can use, and then also the compounding pharmacy can do it. Here in Columbus, the only compounding pharmacy that will make this is Riverside Hospital. Raynaud's phenomenon is another issue that can affect the nipple. So Raynaud's, similarly to how it occurs in the fingers, can occur in the nipple. Basically, when the breast is exposed to cold air, a vasoconstriction process occurs, and basically there's a lack of blood flow to this area of the nipple. The treatment for this is to keep the breast as warm as possible. If the mom is having significant pain associated with this, and that can happen, nifedipine can be prescribed to help dilate those blood vessels. Atopic dermatitis, so eczema or psoriasis, can also occur on the nipple tissue, and this can be challenging to distinguish from thrush, and it's treated with topical corticosteroids. Okay, so here I've made a little table for you that you might want to print out and keep if you're going to be working with breastfeeding mothers. Basically, this is the differential diagnosis chart for nipple concerns, as well as the common causes and the treatments. One complaint that you may run into if you're working with breastfeeding moms is that of oversupply and an overactive letdown. So an oversupply is the breasts are basically producing too much milk. So the way that the mom will notice this is either that when she pumps, she's getting significantly more than she would expect. So typically when you can expect to produce about 1 to 1.5 ounces of breast milk per hour. If you think of it this way, if the average baby eats between 2 and 4 ounces every 2 to 3 hours, then they're getting between 1 and 1.5 ounces per hour. So this mom here, I can pretty much say is an overproducer, whoever pumped this breast milk. So typically if mom is at work for 8 hours during the day, she should be able to produce somewhere between 8 and 12 ounces of breast milk. If this is one pump session, that is a lot of breast milk. The average mom would be pumping as often as she would be feeding the baby at home. So if she would normally feed the baby every 3 hours, she would expect to pump somewhere between 3 and 5-ish ounces every 3 hours, and this mom has pumped clearly about 12 ounces or even 13 ounces, and that is quite a bit. An overactive, the other thing that moms who have an oversupply will experience is that they will feel engorged more frequently than they should, and even they may still feel engorged after feeding the baby. An overactive letdown is the other component of oversupply. Many women with oversupply also have an overactive letdown. Basically, this is the milk ejection reflex comes on very forcefully. Both of these problems are more common with second, third, fourth, and subsequent pregnancies. Women with an overactive letdown will notice that either when the baby is nursing and they feel a letdown, which can feel like pins and needles or even like a burning sensation in the breast as the milk starts to flow. When that happens, the baby may arch back, cough, pull off, gasp. The baby may also be excessively gassy or spit up quite a bit. Reflux in infants and overactive letdown are correlated, although they're not always, 1-to-1 ratio. The mom may also notice that milk forcefully sprays. So milk may go spraying across the room when she lets down. That would signify an overactive letdown. In a baby that is dealing with overactive letdown, you may see green frothy stools. It's not necessarily a concern as long as the infant is not unhappy or having some of these symptoms of gasping, pulling off, and all that. The best way to deal with this, first of all, the oversupply should be dealt with by limiting how much breast milk is expressed from the breast. As we said, you're pretty much going to get as much breast milk as you continue to remove. So if women can reduce how much milk they pump or how often they feed the baby, so meaning that not trying to feed the baby until the baby is demanding to be fed or asking to be fed, that can help. Not hand expressing, not pumping in between feedings. And also when the mom's at work or when the mom's away from the baby, not pumping in excess of what the mom would produce if she were at home feeding the baby directly from the breast. That can all help to reduce the oversupply. For overactive letdown, we suggest that the mom either start by hand expressing or pumping, or let the baby start nursing, but when you feel the letdown, to unlatch the baby and let down into a collection device or into a towel. That can help with that initial spray to keep that baby from having that choking sensation. So moving out of the problems of breastfeeding, I just want to add that we talk about breastfeeding and breast is best and telling moms that they should breastfeed above everything else, but it's not an all or nothing process. Any amount of breastfeeding is going to be beneficial to the mother and the baby. So any amount of breast milk will help the baby in terms of nutrition. Any amount of breastfeeding will help with those, help reduce those risks that can be of benefit to the mother. So we encourage any amount of breastfeeding, even if it's not perfect. I think a lot of moms feel like they have to go all in or they can't do this at all. So after the first couple of weeks of breastfeeding, after that, really that first probably 4 to 6 weeks when you're establishing a milk supply and your milk supply is evening out, women are able to be a little bit more flexible with breastfeeding. Some women choose to exclusively pump. They choose not to bring the baby to the breast at all, but instead will extract breast milk. And once a good supply is established, they may be able to pump only 4 times a day as opposed to pumping, 10 to 12 times a day as they would feed the infant 10 to 12 times a day. Exclusive pumping is a lifestyle that is very challenging and takes a lot of dedication. The pump is not warm and soft, and it doesn't smell good, and it doesn't provide the same oxytocin release that a nursing infant would. Plus, it requires a lot of dedication and sticking to a schedule in order to maintain milk supply. There is something called partial weaning. Once a good milk supply is established, some women are able to basically create what I like to call business hours for their breasts. So when I was nursing my children and they were around 8, 9, 10 months old, I had accumulated plenty of frozen breast milk that I didn't need to pump anymore to get them to a year of breast milk. So I stopped pumping at work, and instead I would just not pump during the hours that I was away from them. And you have to kind of work down, so you have to slowly work to reduce the number of pump sessions and the amount of time while you're away. But then I was able to continue feeding them for several months after I finished pumping while I was away from them. So that is a process that you can encourage moms to try if they're really just tired of dragging that breast pump around, or if they don't want to commit the time to doing that anymore. They may still nurse the infant when they're with the infant and just choose to formula feed when they're away. So breastfeeding with formula supplementation is always an option. There are also additional ways of introducing breast milk. So we use some of these methods. For example, this over here is a supplemental nursing system, or an SNS system. These can be used when there's a problem with the breast or with transfer that's preventing the baby from getting milk, to kind of encourage them to keep working at trying to breastfeed. So this baby's being rewarded with breast milk even though there's nothing coming from the nipple. They're linking that breast milk intake reward with the sucking at the breast. Some babies can be fed from a cup, a syringe, a spoon, or even a finger feeding system. If moms are adopting an infant and would like to breastfeed, there are hormonal options for inducing lactation as well. Some babies will be very, very stubborn about taking a bottle. One of my children was like that, and we had to basically she basically flipped her schedule. So her method was to drink very little during the day as if she was sleeping, and then she would nurse with me all night long. And that's called reverse cycling. So that's another option for moms who don't produce enough breast milk during the day. Their infants may naturally adjust to nurse more at night. Certainly we don't want to dehydrate children, so they should be offered formula or breast milk from a bottle. In my case, my infant refused to drink anything unless it was directly from me, and so that's how we dealt with that. Okay, so as the healthcare provider, there are some interventions that you can engage in to help improve breastfeeding rates. Skin-to-skin contact immediately after birth with early breastfeeding initiation are 2 of the best interventions that you can offer to patients. Lactation support, preferably face-to-face, but there are also e-visits and phone visits that can be helpful. An international board-certified lactation consultant is the person that you want to advise your patients. They have the highest level of training and certification. There is an initiative called the Baby Friendly Hospital Initiative. Baby-friendly hospitals meet a number of guidelines. For example, they have lactation support, they don't supplement, they allow rooming in, they don't offer pacifiers or artificial nipples, except in extreme circumstances, etc. So there have also been a lot of public health initiatives to help improve breastfeeding rates. We do know that any level of support to moms is beneficial, and early face-to-face support by a lactation expert is absolutely one of the best things that we can offer to moms. I do just want to mention, and I said this earlier, that nursing into toddlerhood and beyond is a perfectly normal and wonderful thing for a family to do. 12 months is not a magic number. There's absolutely nothing magical about that first birthday that tells a baby that they don't need mom's breast anymore, that they don't need breast milk anymore. Nursing after 12 months will continue to provide physical and emotional benefits to the toddler. In a developmentally normal toddler, around somewhere between 9 and 12 months, there's a flip where breastfeeding starts to support solid food intake instead of being the primary source of nutrition. Again, that occurs between 9 and 12 months. It's also entirely possible to nurse two children, either twins or two children of different ages. So a mom who's nursing a toddler can nurse through her pregnancy and then again after delivery of the baby. This is called tandem nursing, and one of the really cool things is that the breast can actually help to react to different children, in that it may be able to provide different nutritional components to different children at the same time, so depending on the child at the breast. So breastfeeding in the way that we do it in our cultural pattern in the United States, I just want to point out, does not make for very good birth control. And so it is quite possible to get pregnant while breastfeeding and then to continue breastfeeding through that pregnancy, as I mentioned a moment ago. Okay, so we said weaning. Weaning starts really as soon as formula or solid foods are initiated, and it continues until breastfeeding stops. And breastfeeding can stop gradually or abruptly. We typically don't recommend abrupt discontinuation because this can result in engorgement, clogged ducts, and mastitis. So typically gradual is best, but that's not always the best. That's not always the way that it works out. Sometimes things happen. Mom's unexpectedly away from baby for an extended period of time, and the breastfeeding relationship can end unexpectedly. There's two different ways of going about weaning. One is mother-led. There's different ways of doing this. One is to just simply stop offering to breastfeed, but don't refuse. Over time, the infant may get distracted or may start asking less often until eventually they just don't ask at all. And if you let this go on long enough, and I can't promise you it won't take 2 or 3 years, but if you let this go on long enough, the child may eventually stop asking. Moms can also wean by limiting the number of sessions they have a day or limiting the amount of time per session and just slowly reducing those times until they just decide to stop completely. We talked about partial weaning or the business hours model before. You can certainly set limitations with your infant and with your own self about when you will and when you will not breastfeed. And then if the mom is using a breast pump exclusively, they can wean off the pump by reducing the number of sessions, spacing out the time in between sessions, or reducing the number of minutes per session. So any of those are an option. Baby-led weaning rarely occurs on its own before 12 months unless there's a prolonged separation from the mother. Some moms will come in with a baby who's 6 months old, 7, 8, 9 months old, and say that the baby doesn't want to breastfeed, and typically that's what we call a nursing strike, and this can last hours to days, and typically we just tell the mom to keep pumping through it and to keep offering, and the baby has something developmental going on. It might be a tooth, it might be an illness, and they usually get over it in a couple of days and go back to the breast. After 12 months, a baby may decide that they're not really all that interested in nursing anymore, especially if mom has not kept up with production very well, and so the mom's not producing very much, and so the baby may choose to discontinue on her own. So it's important that the primary care provider is aware of medications related to breastfeeding. Decongestants and certain dopamine agonists and estrogens can all reduce milk supply, so we don't recommend combined hormonal contraceptives or other estrogens within the first 6 months of breastfeeding. Decongestants such as Sudafed can reduce the amount of breast milk produced by basically causing a drying effect. This will not happen in every mother who takes a decongestant, but in those that it does happen to, the effect is typically permanent. So we recommend that moms avoid these unless they are choosing to stop breastfeeding. We know that certain drugs are unsafe for the baby and can get into the milk supply. This includes things like cocaine, PCP, and marijuana. The verdict's still out a little bit on marijuana, and this has been a source of a lot of studies, and it's currently being studied, and so I think there's more information that's going to come out about this soon. Radioactive drugs and imaging. So for example, if mom's under radioactive iodine treatment for a hyperthyroidism or something like that, the mom should not nurse during that time. If the mom receives radioactive dye during a procedure, they may need to pump and dump that breast milk with that first 24 hours. It depends on the contrast dye that's used. Most medications are safe and are minimally transmitted through breast milk, and it's important that you check, but it's still important that you check all drugs with a reputable resource, and I'll show you where you can do that. As far as alcohol, there's a lot of information out there about alcohol and breast milk. The newest research that's available suggests that the breast milk concentration of alcohol will be equal to the maternal blood alcohol concentration. What that means is unless the mother is intoxicated, so unless the mother is at a BAC level consistent with intoxication, there is unlikely to be any effect on the infant. The younger the infant, the higher likelihood of an effect. So if the baby is only 4 days old, it is more likely then that the baby will have an issue. Typically, pumping and dumping is not necessary unless the mother is drunk. If the mom has been drinking excessively, the mom can still pump and actually mix the alcohol-containing breast milk with clean breast milk that does not have any alcohol in it to dilute the proportion of alcohol. That is one option. There are very few times when if the mom were to have one or even two alcoholic beverages that she would need to dump the breast milk, excuse me. And there are some alcohol test strips, but these are not validated they're not scientifically validated. So I would not recommend that you recommend them to your patients. They're also expensive. And basically, if you understand the principles that whatever the mom's BAC is what the breast milk's BAC is going to be, or what the breast milk's alcohol concentration is going to be, and then the infant is going to intake that, and then their body will process it from there, the likelihood of the alcohol causing a major concern is very low. Okay, so birth control. Breastfeeding alone is not good for birth control in most cases. Breastfeeding works really well as birth control if the mom and baby are never away from each other and the baby breastfeeds at least once every 3 hours forever. That's pretty much the only time that it's okay to use breastfeeding as birth control. If the mom is pumping, for whatever reason, this does not work the same way as if the baby is at the breast. The baby needs to be at the breast every 3 hours forever, and that's the only way that it will work as birth control. So it's always good to have backup birth control. Progesterone only and non-hormonal birth controls are the best choices for nursing mothers. Any of the IUDs, the Nexplanon, the mini pill are good options. Permanent sterilization is a good option in women who are not planning future pregnancies, or for partners of women not planning future pregnancies. And barrier methods can be helpful as well, although they have a somewhat higher failure rate for preventing pregnancy than the hormonal birth control options. Estrogen-containing birth controls can be considered if the mother is more than 6 months postpartum and there's a good breastfeeding pattern that's been established. The estrogen tends to have less effect once that breastfeeding pattern is well established. So just to summarize, there's a few recommendations on here with their level of evidence. We do recommend exclusive breastfeeding. It is linked to reduced GI infection. We know that interventions from primary care providers can improve breastfeeding rates. We know that monitoring weighed feedings is the best way to monitor milk supply, although we're only at grade C evidence at this point. And then we know that tongue tie can reduce nipple pain if that is the cause of ankylosing. So if you've evaluated your patient's nipple pain and you cannot find a source related to the mom based on that chart that we showed you, and if the infant's suck pattern seems okay, but the woman's still having pain, that's a good time to get the baby checked for tongue tie. Okay, so here I just wanted lastly to provide you with some additional links. There are so many breastfeeding resources in the city of Columbus, and we're really lucky to have that. The Columbus, Ohio has a wide range of breastfeeding support groups available, and I've linked you with a list of all of the support groups that are available. There are also many international board certified lactation consultants available at all of the hospitals in Columbus, and there are also some private lactation consultants within Columbus. Most insurance companies will pay for a consultation for a new mom to meet with one of those consultants, and so I highly recommend that you send your patients to a lactation consultant or have them see one in the hospital if they're planning to breastfeed. Ina May Gaskin is an author who's written a lot of books on pregnancy and childbirth and breastfeeding, and one of her books, The Guide to Breastfeeding, is an incredible resource that you can recommend to your patients or that you may read as well. There are several links on here, including several websites. The Global Health Media Breastfeeding videos has some great videos that can help to demonstrate latch techniques for new moms, and kellymom.com is just a great resource by a woman with a lot of breastfeeding experience that she uses good evidence-based literature to back up recommendations for breastfeeding. Most lactation consultants I know will send patients to this website. And then finally, as a prescriber, there's an app that you might want to look at, actually two. One is LactMed that gives you information on breast milk and on breast milk and medications and how the medication will affect both the supply and the infant. And then the Infant Risk Center for Healthcare Providers also provides prescription information on commonly prescribed medications for healthcare providers. So all of those are links that you can use, resources that you can use to support your breastfeeding moms. These are some references that may be helpful to you, and as always, if you have any questions, please reach out to me. I'd love to talk with you more about this, and thank you so much.